So welcome to your ankle assessment. We've taken our subjective assessment, so we've talked to the clients about their specific problems, the mechanism of injury, the things that are going to potentially have caused their problem in the first place. We've got two hypotheses, so we're thinking, right, it could be this or it could be this, and then we're going to move into our formal assessment. Starting off then, we're looking at observation. Now, you tend to do observation in a few different planes or a few different views. So looking from the front, we're going to be looking at the attitude of the feet. One of the common mistakes people make when they're doing this is they'll leave shoes on or socks on. So you need to get your client undressed down from the knees down. Attitude of the feet, position of the feet, do they look like they're flat-footed or high arched? So flat feet is pes planus, high arch is pes cavus. That might change the orientation and the movement of the ankle. That might have been a predisposing factor to that ankle sprain. We then turn to the side, and from the side we're looking at the position of the knees, the relative bulk in terms of the calf muscles, the gastrocnemius and the soleus muscle, and again looking at the attitude of the limb on that side. We do the other side for some comparison, and then you're going to turn your client to the back and you're going to look from the back, again looking at things like calf muscle bulk, Achilles tendon, whether that looks like it's in a nice straight alignment, or because their foot's rolled in, you've got some bowing on the Achilles tendon, which is contributing to their problems with Achilles tendonitis. So, following on from observation, we're now moving on to the actual assessment itself. The first part of that assessment, we now move into palpation. Now, depending on the irritability of the tissues, will depend whether or not you palpate at this point, or you leave your palpation to the end when you finish your resisted testing. Palpation, the usual places where you get problems will be around the side of the lateral malleolus. This is where your lateral ligament sits. You might find you get problems with some of the tendons on the front of the foot. So you're using your palpation to try and work out the location of those symptoms, and then using your RAP model on your ankle anatomy to work out what structures are likely to be implicated due to that location. Once you've done that, we then move on to joint clearing. Now, to clear the ankle joints, we're going to clear the knee joints and we're going to clear the toes. Knee joints above, toes below. Mrs. Mofo, if you can bring your heel towards your bum on your one leg. Now, if she's got full range of movement there, there's no pain or discomfort. She's mute. You add some overpressure. You get a sense of the end feel of the joints. Do the same on the other side for me. Any pain or discomfort there?
No.
She can speak now. We add some overpressure there. The end feels feel the same. Straighten out this leg for me. Any pain or discomfort in the knee?
No.
And then we add overpressure there. Shut up. And then do the same on the other side. She's such a girl. So the knee joints feel the same and didn't reproduce symptoms into the ankle. Now with your toes, scrunch your toes up for me. Now Mrs. Mofo has a problem with her big toe, dropping a 20 kilo plate on that toe has probably caused some degenerative change, but don't mention the word osteoarthritis. So subject to them being able to scrunch the toes up, separate the toes, and there's no pain or discomfort produced in the ankle joints, you've cleared the joints above and below. We then move on to active range of movements. This is about take 372 because Mrs. Mofo couldn't work out what I meant by bringing her feet towards her knees, and she was bending her knees, not pointing her ankles. So bring your foot towards your knee on both sides, very good. Look at the range of movements, does it look the same? Look at the quality of movements as you moved into that range, and any pain as you move through range of movement there. No, there's no pain. Point your toes towards the wall. Again, look at the range of movements, look at the quality of movements, and check for any range. Now, we're going to get you to turn your feet. This is complicated, so she'll get it wrong. Turn your feet in on both sides. I'm not moving her, this isn't passive, this is active. And then turn your feet out, so you've now got inversion, eversion. Pain or discomfort through there?
No.
Passive range of movements. So I'm now going to do exactly the same thing. This is her injured ankle, this is a non-injured ankle. So I'm going to move into passive, what we call dorsiflexion, assess the end feel. Passive plantar flexion, being careful not to squash the heel down onto the bed. Passive inversion, and then passive eversion. And I'll do exactly the same thing, going around to the other side of the bed on the other side. So passive dorsiflexion, assess, think about what it felt like on the other side. Passive plantar flexion, again compare that to the other side. Passive inversion, and then passive eversion. Bear in mind I'll be around this side of the bed at that point rather than leaning over the bed, because it's important you look after your own posture and backs, so you wouldn't want to be in that position. Once we've done passive, we're now going to move on to resisted testing, and for that I'm going to come onto the end of the bed, so I'm probably out of shot. So Mrs. Mofo, can you now bring your feet towards your knees like that for me? Hard as you can, bring the power on. So we're feeling for strength, both are the same, so she's moving through a full range of movements against resistance, and we'd use the Oxford scale to grade that. That would be a 5 out of 5 on the Oxford scale. Again, push into my hands, so push, push, push. So apart from moving back on the bed, because she hasn't put the brakes on the couch, that's a 5 out of 5 for plantar flexion. So inversion, try and turn your foot in for me, and I'm going to resist that movement. So she's trying to invert the foot, and I'm trying to evert the foot. Try and turn your foot in, and I'm trying to turn the foot out. So that's the inverters. Now you're going to try and bring your foot that way, so into eversion, and I'm going to resist that. So I'm trying to push her into inversion whilst her everters, perineals, longus and brevis are working. And again, if you try and bring your foot out, I'm trying to bring the foot in. That's your resisted testing.